to welcome you to week 3 of the evidence-based practice course. This week we'll be discussing outcome measures and looking at the importance of outcome measures for evidence. When we talk about what is an outcome, let's first think about what outcomes mean to us. If we start eating better, eating more fruits and vegetables, or start exercising, we want an outcome to occur. We want something to happen that makes something different. We may want to feel better, we may want more energy, we may want to lose weight, we might want to have that glow that comes with exercise and eating better, but we want something to happen. So an outcome is a measurable, individual, family, or community behavior or perception that's measured along a continuum and is responsible to clinical interventions. So something that we want to change that takes place over a continuum and is responsive to some kind of intervention. An outcome measure, and if we go back to what is an outcome measure for eating better or exercising, is, are we going to lose weight? Are we going to be able to walk further or run further? Or for eating better, are we going to, if we have more energy, are we going to be able to add more activities into our daily life? So we want to think about how we would measure that. So an outcome measure is a set of items that are used to create scores that are intended, and this is for clinical practice, intended to quantify a patient's performance or health status that's based on standardized evaluation protocols or closed-ended questions. When we talk about closed-ended questions, we mean that there are choices for those questions, not how you doing today. So where somebody can say, oh, I'm feeling great, I'm feeling not so good, but really to look at things that are closed-ended, that give people choices, that have been evaluated. Those measures have been evaluated and really tested to make sure that they are going to provide the best information that you are looking for in practice. And as I was getting ready for this, I was thinking about how when I first came out in practice many years ago, most people had what we would call homegrown measures. They kind of knew what they were looking for, and they sort of knew that their measures made a difference. And as we talk about reliability and validity throughout this PowerPoint, we'll see that there are certain things that really determine that, not just, I know it makes a difference. So keep that in mind as we go forward. So why do we measure using outcome instruments? Why would we measure patient characteristics using standardized outcome measurements? And we often use those for documentation in electronic records. And everyone here is going to have an opportunity to use electronic records either in their fieldwork or in practice. They're used in clinical information systems. So information systems that are gathering lots of information about patients to see what is happening. They're used, outcome measure instruments are used to develop clinical knowledge and professional education. So the more information and the better information we have about people, the more we can determine, we know what makes a difference, and also how to then teach that information and to bring that into professional education. And the last way is that it's used in resource allocation and accountability. Everyone in this class is going to be held accountable for what they do. And one of the best ways to know that something is making a difference is by using a standardized measure in practice. So in patient care, why do we use outcomes? We use it to track to establish baseline status for a patient. So we want to know coming in where they are, so then we can see where they're going to go, hopefully going to go. And that's the second bullet, is to track a patient's progress to determine if what you've been doing, if the plan of care that you've implemented is effective. You want to be able to communicate to patients that they have made a change and to tell them in a quantifiable manner that they are making progress. For many patients and clients, the getting better process, the rehab process, isn't the most fun for them. And so if you can let them know that they are improving, it really is very helpful. You can let payers know that patients are making positive changes, and that can enhance your reimbursement. And then by providing data that you've collected over time to improve care for your patients and clients. Now I want to talk a little bit about some of the ways that we look at the properties of outcome measures. In the chapter that you're reading today, there's a lot more information about this, and it's really good to read the chapter to get a sense of the variety of psychometric properties or measurement properties that are used to determine whether an outcome measure is valuable or not. But I want to focus today on two of the ways that we look at outcome measures, and that is for validity and reliability. And when I mentioned at the beginning about these homegrown measures, these measures were not tested. They were not viewed, it was not viewed as really that important. Measurement was important, and knowing that people made a change was important. But there really, at that point in time, wasn't a lot of work done on the outcome measures to test whether they were valid and reliable. At that point, every hospital, every clinic had their own measure that they felt was valuable, but did not always test them. There was probably some testing going on, but in the places in which I worked, that was not viewed as really that important. There were other things definitely that were important, and good quality intervention and treatment was really viewed as important, but reliability and validity were spoken about a little bit, but it wasn't always part of the plan. So what is validity? And validity is the extent to which an instrument is measuring what it is supposed to measure. And going back to your own health changes, look at a scale. Does the scale really measure what it's supposed to measure? Some scales do. Some scales are not always reliable, measuring at the same time, or they may not, and we'll talk about that later, but not always. It's somewhat valid, but is it really the most valid? And we also get into that in the health field with measuring body fat and other areas. So it's the extent to which an instrument is measuring what it is supposed to measure. There are a variety of types of validity, and again, the chapter discusses a lot of this and goes into a lot of the other psychometric properties of a measure. Criterion-related validity. It's a method for assessing the validity of an instrument by comparing its scores with another criterion known already to be a measure of the same trait or skill. For example, when we talk about older adult driving, the gold standard for measurement of whether somebody can still drive is the road test. And there are other tests that are easier to apply, safer to apply, and just take a lot less time, that people test to see how that measure, quote, measures up to the road test. And there's a lot of work being done and has been done in the past and being done going forward to really look at how does that measure up to the road test. Concurrent validity is the extent to which a procedure correlates with the current behavior of subjects. So how does this measure correlate with what's going on presently? Predictive validity, and it's the extent to which a procedure accurately predicts a subject's future behavior. Going back to older adult driving, there's a lot of work that has been done and being done on whether measures can predict future behavior for older adult drivers, and one of those behaviors is crashes. So will an outcome measure, if I take or give a measure to someone who comes to the clinic to be tested for their driving abilities, will that test predict in the future that person's potential for getting into a crash? And obviously getting into a crash requires a lot of things to occur, but those cognitive tests, those behavioral tests, those motor tests are really assessing whether that we can predict that someone will get in a crash in the future. Content validity. That type of validity looks at whether the individual items of a test represent what you want to assess. And construct validity is the extent to which a test measures a theoretical construct or an attribute. So constructs can be abstract concepts such as intelligence, self-concepts, motivation, aggression, and creativity. And you want to see if an instrument reflects that. And it's measured by convergent and discriminant validity. So will those people who are, say, creative be discriminated from those who are not? Or you could use that for aggression as well. Will the construct of aggression be determined by that measure, and will it discriminate between those who are not aggressive? What affects validity? Some of the things that can affect validity, so measuring what you're looking to measure, are the test-related factors. The criteria to which you compare your instrument may not be well enough established. So you're going down the path of measuring something, but you're not really sure if it's really the best established. Intervening events can take place so that what's occurring for the person either at the time of taking the test or a little bit later can really intervene and change the validity of the test. And another factor that affects the validity is reliability. So reliability and validity are really tied together. So what is reliability? So it's consistency of measurement. So for example, when you ask how reliable is that type of car, that brand of car, you're asking, if I get into the car on a daily basis, will I have the same performance? Will it be reliable? Will I know that every time I use it, it will hopefully drive? The same thing with getting on the scale. Even though we get on a scale and we want to know that it's going to measure things the same way each time. A reliable test produces similar scores across various conditions and situations, including different evaluators and testing environments. So when we're measuring things, we want to make sure that the test is reliable so that we know that we can get the same scores, so that a difference in score is not based on the failure of the score to measure it reliably, but the changes that the person is making. So we just had a quick overview about outcome measures, but now I want to talk a little bit about the Rehabilitation Measures Database, because for the most part, as students and as clinicians and as researchers, you want to be able to, the best way, the easiest way I should say, to have that information is to be able to go to a site that can provide you with information on outcome measures so that you do not have to reinvent the wheel each time you use an outcome measure. So what I want to do for the remainder of this session is to go through the Rehabilitation Measures Database, which is out of the Rehabilitation Institute of Chicago, and it's at www.rehabmeasures.org, and it is a funded by grants website that has information on a variety of outcome measures in rehabilitation. And I had the opportunity and pleasure of contributing to the Rehab Measures database to really look at one of those measures and to find the information that is being posted, and we'll talk about that. So let's go to rehabmeasures.org. And what you will see is that it's the rehabilitation clinician's place to find the best instruments to screen patients and monitor their progress. It is really a wonderful place to go to find a wealth of information about the measures that you would consider using in practice or in research. So, for example, now you'll see in the middle there is an ad. They do have some ads, so but they're not geared to rehab particularly, and we can ignore that. It's not about cars. So if you'll see towards the bottom, there is information, a drop-down menu related to areas of assessment and diagnosis, length of test, and the cost that you're looking for. So let's say that we are looking at we want to look at activities of daily living in stroke. We want to see all the measures that there are, and we have no preference for cost. So we put that in, click on search, and you will see a long list of measures. The top one that is there is the functional independence measure. But if you click on bottom, towards the bottom, you'll see instrument review. But let's go scroll further down, and you'll see the Canadian Occupational Performance Measure. And you'll see that it assesses an individual's perceived occupational performance in the areas of self-care, productivity, and leisure. It takes between 6 and 30 minutes. Training is required by reading an article or the manual, and it's not free. And but it looks as though, from what I can see, that it's been designed for use regardless of diagnosis, but it's been validated with patients drawn from the following populations. So you'll see that it has been validated on the stroke population. And there is a link down towards the bottom for available for purchase at the Canadian Association of Occupational Therapists. You go to the external link, and on the right is the instrument review. So let's click on that instrument review, and you'll see that there is a lot of information about the COPM. A link to purchasing it, the purpose, the acronym, and who it's been reviewed by, and the reviewers who reviewed it and the summary date. So Here is the description of the COPM, what the ICF domain is, and that its participation, and the time to administer it. Now that's a few minutes different from what it said before, but there may be different ways. It's really within the same ballpark. And I want to mention a little bit about the ICF domain. For the activity that you'll be doing today, I'll be mentioning this, hopefully mentioning this in the intro as well. I've mentioned it in the intro, that you'll also be looking at the Rehab Measures database as part of the activities for the course, but really referencing it towards the occupational therapy practice framework. The ICF is extremely valuable, but we'll also be talking in the course about the practice framework and want you to be able to have experience using outcome measures and evidence as it relates to the practice framework. The equipment required, there's none necessary. Training, it's not necessary. The actual cost information, the populations tested, and there is information about the standard error of measurement, and that is described in the chapter you'll be reading for this week. There is retest reliability information on stroke and on other diagnoses, interrated and intrarated reliability. There is information on criterion validity in arthritis and community dwelling disabled individuals, as well as construct validity information. There also is an extensive bibliography list for the COPM, and when you are looking for a measure for a specific diagnosis, it really does help to go back to the articles to look at them, to look at that information. And having the bibliography at your fingertips at the Rehab Measures database is really wonderful, because it gives you the opportunity to, without doing a lot of searching, to really have it in a very short period of time. So that's it for today. For the information, as we've said in the past, if you have any questions, go to the discussion forum or email us. Here's information about outcome measures that really can help you to understand more information about evidence, and understanding more about the articles that you'll be reading, the abstracts and citations that you'll be looking for, to help you understand, to critically appraise the evidence that you'll be looking for throughout the semester and throughout your career. So, have a good day.